So I'll move to the next presentation, which is from Dr. Savitri Sharma. That is a practical microbiology for clinicians. Dr. Savitri, you must be all knowing, she is the Director Emeritus of the LVPA Laboratory Network. She is the President of the International Ocular Microbiology and Immunology Society. And she has too many firsts in her area. Like she identified the first acanthamoeba keratitis, microsporidial keratitis, and more than anything, she is my best teacher. Welcome, ma'am.
Good afternoon, all of you. Thank you so much for having me here. It's a pleasure to come to Kerala, really. Such a beautiful place. We don't get tired of looking out of the room. It is just, it's a real heaven to look outside at the greenery that we see. We are very pleased to be here. So I'll just begin by thanking Anil for having me here and giving me a chance to talk to all of you. Is my audio okay? Yeah. Okay. So let's begin. As he showed I like the introduction that he gave. You have lots of organisms around and on your body, inside your body. Actually, you should be loving them and not be afraid and worried unless we see them as an infection, which is very rare. Actually, the infections we are seeing is so less compared to the abundance that they are in there. So much there. But they don't they are not really our enemies, and very few, and many times it's because of our own mistakes that they end up giving us infection. So here is a diagram to show you that various types of organisms are there: bacteria, fungi, and now I'll be talking a little bit about parafungus, which is not real fungus but looks like fungus, viruses and parasites. You can see here there is my arrow will show. Yeah. So these are, we have recently or newly we are recognizing all organisms are always there. It's only our inability to recognize them. And we end up recognizing them now and then we say that they are emerging or they are new. But they have always been there, and it is we who have been lacking the skill to recognize them. Can anyone say what these are? Demodex. You see on your, you are seeing in patients on the eyelashes, and then they also can cause keratitis. So clinically, we would like you to look at a case and tell us whether it is viral or non-viral, because microbiological methods of diagnosis depend very much on that. We have different set of tests for looking at non-viral and finding out non-viral, which would consist of all except viral. And viral requires different set of methods to identify. So we believe in direct microscopy of the cornea scraping. The sample should be directly from the cornea and not from conjunctiva or somewhere else. And we of course believe in culture so that we can prove what we have seen in the smear, whether it is confirmed or not, and it also gives us organism to do the antibiotic susceptibility and further tests we can do. But it is a direct microscopy which gives the immediate and early diagnosis. And of course, the laboratories which are able to do antigen detection methods, they are needed for viruses, and molecular methods are also more in use for the viral diagnosis. And the central part of the whole thing is the clinical correlation. Now, microbiology is giving a name of an organism which doesn't make sense to you, will have to be seen with a pinch of salt, because you need to make sense of what has been reported. This slide I made just for those who do not have an institutional setup, and you can have actually in your own clinic just very few simple things. The only thing expensive in this is the microscope, which again, if you are buying just a general binocular microscope, may not cost more than 50,000 or so. A good ones cost actually 1 lakh. Very good microscopes are about 1 lakh. but 50,000 also you can get and have very small things. Now I have highlighted here trypan blue, which we recently have added to our armamentarium, especially in the secondary centers. LV Prasad Eye Institute, as you know, has more than 20 secondary centers, where small hospital with one doctor and a few nurses. So there also we have microbiology setup, mostly consisting of these which are listed here. Anil mentioned that in especially abroad in Western countries, they see more of bacterial keratitis, and therefore they do not so much worry about doing the laboratory diagnosis, because they consider most of it is bacterial and they treat with broad spectrum antibiotics. But we cannot really do that in India, because going by what the data he gave, and here is I have a comparative data of different countries. The blue ones are bacterial and red ones are fungal. So you can see in some countries, India included, Thailand, we have in Africa, we have so much of fungus. So you cannot do without checking the cornea scraping whether it is bacterial or fungal, and then only think of treating the patient. Otherwise, you will be making a mistake if you consider everything as bacterial. However, it is in US and other Western developed countries, the picture may be different. This is just to show that in our secondary centers, this is a setup I mentioned, and we have been able to do cornea scraping, direct microscopy. We have now added trypan blue. Those who are doing KOH is the oldest method that is still being done for identification of fungal elements in cornea scraping. So this is to show you that in KOH, not only fungal elements. I was talking to Anita about this microsporidia. You can see these are microsporidial, rice grain like things. If with a proper lighting, you will be able to see the microsporidia. Acanthamoeba is seen very clearly in KOH, and with little bit difficulty you can see even the nocardia. So this method, a very old method, it can be just be mastered by you yourself, and not even need a microbiologist to identify many of these elements which can be present in the cornea scraping. Trypan blue is something which is available to you after in the operation theatre. You can make just directly, I add just 1 drop of glycerol in 5 ml of trypan blue to keep it moist, and then you can just put that 1 drop on the cornea scraping, and then the filaments become blue in color. So they become more clear compared to KOH alone without any color. These are all gram stain pictures. Even you can keep gram stain is commercially available, a set of stains. You can learn, it's very easy. It's written on the bottles how to do the gram stain, and you can learn that. So having these is very useful. This is one of the studies we have published in British Journal of Ophthalmology based on what we found in secondary centers just on the basis of gram stain and KOH. These are again to show you acanthamoeba. This was a case in Bhubaneswar. I had seen the Dr. Shrikant Sahu was very sure that this is going to be fungal, this patient. And when he came to, he sent off the patient giving antifungal. After he was so sure, he comes to the lab asking, I just want to find out. I've sent off the patient already, and we saw acanthamoeba like this. So this later on he published this, that how mistaken he was. KOH. Very clearly you can see acanthamoebasis. So it can be often misdiagnosed, acanthamoeba keratitis, and mostly we misdiagnose as HSV, but there it was fungal. In 45% cases we found in an analysis that 45% cases are thought as fungal keratitis without scraping, acanthamoeba. And the classical features ring infiltrate is very, very misleading, because we do think it is pathognomonic of acanthamoeba. But here is one case we published that looked ring. This is another one, Dr. Sujata Das in Bhubaneswar. She saw ring infiltrate and she said it's acanthamoeba. And what you can see below in this plate that it is growing Staphylococcus aureus and there was no acanthamoeba in the smear at all. Clinical pictures, as he said, can be misleading, and you can have surprises like this. So I really believe in the power of direct microscopy, whether you learn it yourself or you take the help of a microbiologist, but do that. And this is to show you that even acid-fast bacilli, you can just see directly in the smears and make a diagnosis of mycobacteria, which can be treated. You don't need culture, just 2.5% amikacin you treat, and they respond well. Culture, if at all, it is a difficult thing. We have not been able to do a culture setup in our secondary centers. We are trying, but we are finding a lot of difficulties in finding a good technician. Microbiologists will never agree to work in secondary centers of an eye hospital. And then to have a setup where you can make media and do the cultures and train the technician is very, very tough. But at LV Prasad, in our centers, tertiary centers, we have, and the media that we use are listed here for corneal scrapings. These are the media we use, and we collect these scrapings in the OPD itself. You need to take the media slice and media to the OPD, and the ophthalmologist under slit lamp magnification, you take the samples and directly you put it on. I have never recommended a transport media. Many people ask me, why can't we do that? I have no experience, and I feel it is not going to be very useful. It is small samples because you have to take multiple times and very small quantities. So how would you transport that? And you cannot get good results, I feel, by transporting. So we do not recommend that. You can collect other samples. If patient is using contact lens, you can do that. You can also collect biopsy, corneal buttons, etc. These are some pictures of the method which we use is KOH with chalcofluoride, but this requires a fluorescence microscope. The efficacy and the results are much better with the KOH when it is added with chalcofluoride, as you can see here. These are nocardia, acid-fast organisms. Once you suspect in gram stain, you can do acid-fast stain. This mycobacteria I already showed you. And this is another one to show you that fungus, to say it is fungus, the diameter of the filament should be 2 micron or more. Thinner than that is nocardia. So this I wanted you to see the diameter of the filaments. Gram stain, it can be gram positive or gram negative. What's important is the filaments and the septae present inside that. So color is not very important as far as fungus is concerned. When we culture, we always need to follow a criteria whether what we are culturing is significant or not, because as was told, the bacteria are everywhere, so you can get as a contaminant also. So we follow the formula that growth should be plenty, confluent growth of the inoculum and solid media, as you can see, large amount of growth, or same growth in more than one medium, then we consider it as significant. And there should be consistency in what you saw in smear and what has grown in culture. You can't have two different things there and think that it is relevant. Antibiotic susceptibility, people do using Kirby-Bauer disc diffusion method, the left side mainly, and we can also do MIC. This is e-test for getting MIC. How do we identify fungus? Actually, you can learn a little bit. There are aspergillus with greenish color. Now we have a bug buster group, which is in Hyderabad. We have made for cornea specialists. So we sometimes send pictures on that. Many people send, and looking at the green color, you can say it is aspergillus flavor. Some of the fungi can be easily identified just looking at the colony. So this just to give an example of that. This black fungi like alternaria shows you black filaments, and even the corneal ulcer can look black on the surface, and colonies are also black. This is candida, you can see yeast, which is very rare. In Indian situation, it is just around 1 to 2% of patients may have candida. It's more common abroad. Now I'll just tell you something about what we have been working for last 4-5 years is Pythium, Some people pronounce this as pythium, which looks like fungus, but they are very broad and they are aseptate, no septae in them, or very, very few septae may be there. What's important is they grow on blood agar, not like fungus, they just flat, and they just have feathery edge, but they'll be flat. And we have developed a method called zoospore formation, which is not really necessary for identification, but for us to confirm that it is pythium, we follow the, and this was one of the very exciting days for us when we found this zoospore formation, and we have published that almost 6-7 years back actually. So now, why is it important? A PhD student worked on this for 4 years, and we have done animal experiments and many things. The most important thing for you is it will not respond to antifungal drugs. Natamycin will not be useful for this case. You need to recognize this and treat with linezolid, azithromycin and linezolid. So then only it responds. Microsporidia, we already talked about. I think you know that keratoconjunctivitis and stromal, two types are there. Keratoconjunctivitis is usually self-limiting. So even if you see it, and clinically it is very, very clear with multiple punctate superficial lesions on the cornea. Whereas in stromal is something which you find very big size of microsporidia. Again, indirect smear is the only way. There is no culture available for this. We identify only by direct smear, and in stromal they don't really respond. Very long history, waxing and waning, they may be thought as viral for many times, and then they respond, they do not respond to the drugs. We have tried many things like fumagillin, albendazole, it doesn't really respond, and we have to go for keratoplasty. On this we already discussed, I'll skip that. Acanthamoeba, again there is culture which is non-nutrient agar. It's not very difficult culture actually, but you don't see colonies. You have to see the plate under the microscope and then find out, and you have to learn how it looks under the microscope. These are the cysts of acanthamoeba on a non-nutrient agar. Many of the laboratory, I'm sure Kerala is such a developed state, the microbiologists must be having Vitek method, nowadays. Earlier days when we did MD, we had to learn how to identify bacteria by biochemical reactions. But now we have these machines which make it very easy and very accurate. So every lab will be doing similar job and there'll be no variation. And it's a very good method to do sensitivity as well as identification of bacteria as well as yeast. I don't know whether moldy top is available in Kerala in any place. In Hyderabad, we have two places where moldy top is available. For some organisms like Nocardia, mycobacteria, biochemical reactions we cannot identify. Vitek also does not identify. We need moldy top for that. Otherwise, we just report atypical mycobacteria or Nocardia. Is that, am I running out of time? Yeah? Yeah, so then I'll skip these viral things, just want to say that sequencing can be done nowadays because a lot of information is available about DNA sequencing, and sequencing was the one which helped us identify pythium. So unusual new organisms can be identified. This is about I will just skip this PCR, but there might be some labs which are doing PCR and you can send your samples to them. I will skip this. So it is just good to remember that direct processing without resorting to transport media is the rule. Discussion with microbiologists prior to sending sample will help, and you need to develop your own skills in direct microscopy. And you need to tell the microbiologists they must keep the plates for a long time, at least 1 week or 2 weeks, the cultures. Otherwise, they usually discard in 48 hours. With this, I thank you for your attention.
Thank you, ma'am, for the excellent talk. Very comprehensive and as expected, excellent in academic.